Okay, so welcome to the College of Public Health and Human Sciences Research Seminar. I'm Marie Harvey, Associate Dean for Research in the college, and I'm delighted to see so many people coming into the audience here to participate in this very exciting seminar. So today, I'm going to introduce Jeff Luck, who is an associate professor in our health policy and health management and policy program here in the college. The health management program is a co-sponsor of this seminar and a host. And so I'm delighted to see that we have quite a few students coming in. And so I am now going to pass it over to Jeff, who's going to introduce our speaker, and he's going to moderate the seminar, and he's going to tell you a bit about how to put your questions, how to ask questions in this webinar presentation. Okay, Jeff, take it away.
Thanks, Marie, and welcome everyone to our seminar. Just to let you know a little bit about the electronic logistics, Dr. Yano is presenting only by Zoom today. And so for security reasons, we're in a webinar format. So that means your microphones are muted, and also the chat is not working. But if you have a question, please use the Q&A feature down at the bottom of your Zoom window. Type your questions in there. I'll be moderating all of those questions when we get to that point of the seminar. And so I'm delighted to have Dr. Becky Yano join us. Becky and I have worked together for a long time at Rand, VA, UCLA. She is an adjunct professor of epidemiology at the UCLA School of Public Health, and she directs the VA Center for the Study of Healthcare Innovation, Implementation, and Policy at the VA Greater Los Angeles Healthcare System. There are several VA research centers nationwide. The GLA Center is one of the largest and ranked the highest in impact of its research. So it's a really remarkable collection of scholars there. Becky's also a senior research career scientist at the VA, which is sort of the VA equivalent of an endowed chair. And she is director of the VA Women's Health Research Network. And so today she's going to be talking about transforming care for women veterans in VA. So Becky, I won't take any longer, and thank you for joining us.
Thank you, Jeff. It's a pleasure. Welcome, and thank you for welcoming me to talk to you today about transforming healthcare for women veterans through embedded research in the VA healthcare delivery system. I wanted to go ahead and give you first just a brief overview of the VA as the largest national healthcare system we actually have in the United States. We have over 1,200 sites of care in every US state and territory. And the VA serves a population of over 9 million eligible veterans, not counting up to 2 million more who may be eligible for VA care under a newly passed PACT Act on toxic exposures. A veteran's eligibility to get care at the VA is focused really chiefly on service-connected disability related to military service. And we are also a safety net provider for veterans with low income. And this is a lifetime relationship, which is different than most health systems, as it really runs from military discharge to enrollment in the VA, all the way to nursing home and home care. And the VA benefit side even includes the death benefits. So it's really all the way through a veteran's life. The VA delivers comprehensive services in over 170 hospitals, 1,200 clinics outside the VA, community living centers, and also offers a very wide spectrum of social services. Many veterans are also dual users of VA and non-VA care, including Medicare users and VA versus private sector health plan, especially if they're employed or a partner is. And the VA also pays for community care for services it either cannot provide in general or cannot do so in a timely way. One of the key aspects also of the VA is its educational mission, and the VA is affiliated with over 1,200 academic institutions nationwide, with over 100,000 students or trainees in over 45 disciplines running through our programs every year. VA is also critical to training the US physician workforce, with about 1/3 of all residents and 1/2 of all medical students receiving all or part of their clinical training in the VA. We also serve as a backup for the Department of Defense medical care during wartime. So I have had colleagues pack up and head off to Iraq and Afghanistan and other theaters, and assists the US Public Health Service during disasters. So when we had the Northridge earthquake many years ago, VA was setting up the tents, working with Department of Defense to fly in additional mobile hospital supplies, the whole 9 yards. Now, most relevant to today for me is that they also have a long history of intramural and extramural research, and that was originally designed and designated to recruit the best clinicians possible for veterans care delivery. Currently, over $1 billion of research is conducted at VA each year, and the VA Health Services research budget has increased substantially over time, increasingly aligned with VA health system priorities as well as veterans' needs. So let me shift to the health and healthcare needs of women veterans in particular. Now, women have always participated in the military, and even in the earliest American wars, women disguised themselves as men or served in non-combatant roles behind the Army lines. It wasn't until the Women's Armed Services Integration Act of 1948 when women were finally made permanent members of the armed forces, with an aim also at that time in the Integration Act to eliminate racial discrimination and segregation. There was, however, a 2% cap put on the proportion of troops that could be women, and there was actually in the law something that said that women were never allowed to command men or be in combat, that far back. Now, during the Vietnam War, Congress lifted that 2% cap, but only after they tried enrolling male military whose intelligence levels were below typical standards. Once they lifted that cap, women's participation in the military increased exponentially, and women are now actually over 15% of active duty service members and over 20% of the new recruits, and increasing. And that obviously has a very major impact on who we see in the VA healthcare system. So to give you an idea, the number of women veteran patients, there are about 2 million women veterans in the United States, and 36%, now closer to about 40%, are enrolled in VA healthcare. There's been a doubling of the number of women patients in the past 10 years. You can imagine if you've got 5,000 women patients now, but within a year you could have, or 2 years or 3 years, you could have 10,000. That's going to have an impact on who you hire and how you move forward. They are also now the fastest growing segment of new VA users, which require the VA to pay attention to healthcare delivery resources, clinicians, staff mix, and the like. The age distribution of women and men veteran patients in VA is also quite different. 88% of women veterans are under 65 compared to 54% of men, and 42% of women veterans are under 45 years of age versus 13% of men. That has ramifications for reproductive health needs and a host of other things. So the average age, as you can see, is nearly 15 years difference on average between women and men who use the VA. Now, racial ethnic distributions also vary. Women veterans are more likely to be racially and ethnically diverse compared to male veterans. So there's a lot of intersectionality going on in terms of risks, resilience, healthcare needs, and the like. So in terms of the actual healthcare services the VA delivers for women, basically it's all the same services that are available to men: primary care, specialty care, mental health, hospital care, nursing home, etc. But women may have to go to more visits and also more likely to have to go outside the VA to get the same level of services. There's also the issues of ensuring delivery of gender-specific care and reproductive health services, including breast and cervical cancer screening, contraceptives, menopausal management, gynecology care, etc. With one important exception, and that is the VA cannot provide maternity care on the basis of legislative and regulatory limitations. So maternity care is actually paid for by the VA among community-based obstetricians and gynecologists. And every VA has an in-house maternity care coordinator to help coordinate services between providers and VA, and to make sure women continue to use other services they need in the VA during that time. At this juncture, VA only covers about 7 days of newborn care, so women really do have to have other healthcare coverage as well. Now, I used to have an exception that said delivery of abortion counseling and services, and you might have imagined that since the overturn and conclusion of Roe versus Wade under the Dobbs decision, that this would still be the case. But interestingly, that is not the case. The VA is a federal provider of abortion counseling and services to ensure that women veterans have access to needed services for their health and healthcare across the country. That could be its own talk just on how that's been accomplished, and the kind of fascinating ramifications for how you protect providers and staff in states that have very strict abortion laws. And I'm happy to field questions where we have information or at least data. I can't speak for the VA officially in policy, however. There's also been a history with these changes of gender disparities in VA care that have been somewhat persistent. Women veterans have much higher rates, on a positive note, of breast and cervical cancer screening, over 90% compared to civilian women. But women veterans in VA experience less guideline concordant care for diabetes and heart disease, and lower non-gender specific screening rates, for example, for colorectal cancer. There's also been some gender disparities in patient experience, with women rating their care as less accessible, less continuous, and less coordinated. We also have done a study on VA emergency room readiness for women, which varies quite a bit. In large academic programs, they're often linked to their university affiliate, and they figure out how to provide emergency care for especially rare conditions. But we also have anecdotes from women who say they've come into the VA pregnant with some kind of complication, and having staff say, "Oh my God, you're a woman," or "Oh my God, you're a woman and you're pregnant. We don't know what to do." So there's a lot of work that's gone on in that area since as well. And I'm also sad to say that there's been substantial harassment by male veterans on VA grounds, and I'll talk more about that a little bit later. So I did want to, before I talk to you about some transformation initiatives that have been just really exciting to be a part of, give you a notion of how we actually use research to improve women's care in the VA. So we have, as you can tell from the title, an embedded research workforce comprised of clinician researchers and social scientists. I'm an epidemiologist by training myself. And because of this embeddedness, we become knowledgeable of the needs of veterans and the health system. Clinicians get what we call protected time for research. If they get a research grant, they get as much as 30 or 40% protected from seeing patients in order to run that trial, while social scientists like myself get salary from research or operations, meaning medical care dollars along the way. Most of the researchers have academic appointments in affiliated universities, which the VA supports because it gives them additional notions that we are rigorous and working at certain standards of research. In addition to that traditional research workforce, we also have clinical leaders, innovators, and other implementers like system redesign, system engineers, data scientists, improvement staff, and given this audience, I wanted to note also public health trained staff who are sometimes trained in research and sometimes act as partners, helping give us entrees into clinical environments for us to do our work. For example, we have the VA Office of Women's Health and the Women's Mental Health group in VA Office of Mental Health and Suicide, who are our partners, and they have folks that are testing innovations in care models and new ways to coordinate services all the time. For us, this is a mix of operations and research funding, both locally, regionally, and nationally. So my VA Health Services Research Center of Innovation is actually on the far end of this. 50% of our dollars are traditional research grants, kind of like NIH, and half of it is operations dollars, where the head of the Office of Women's Health said, "We need help evaluating burnout among women's health primary care providers. Could you help us? We need help with some kind of congressional mandate," which I'll also talk about in a moment. And then we have traditional research and other federal and non-federal grants. So VA-based researchers, again, with our academic appointments at our affiliate universities, will bring in NIH, PCORI, ARC, and other kind of funding along the way. It's also not uncommon for us as embedded researchers to get, let's say, modest seed money from the operations partner at our local medical center or in central office in Washington, DC, to evaluate a problem. And we do this with the most rigorous methods we can. And then that becomes preliminary studies for our research grants. So there's a very organic relationship across these. And then the rest of our research, as I mentioned, is akin to NIH grants, with the exception that you have to be a 5/8 VA employee. There's also the VA Quality Enhancement Research Initiative, or QUERY, which tests strategies for moving research evidence into routine practice. They fund randomized evaluations partnered with operations all along the way, and is often a mix of planning grants, pilots, full randomized trials, and the testing of strategies that spread evidence from 1 or 2 VA medical centers to whole VA networks or to the whole system nationwide. I've had randomized trials, both varieties, the kind that have full human subjects protection committees, as well as doing a whole trial where I never had to talk to anyone in an institutional review board. So what problems needed solving at the outset here? Well, when I got started in this work, most research was on men. And in fact, that's still true today in and outside the VA, even though women are more than half the population. But the resulting evidence, not surprisingly, may not always apply to women. So the focus here is on increasing the equitable benefit of VA research through greater inclusion of women veterans, and to increase the funding of research focused on women's health and healthcare needs as well. We needed an infrastructure also to support multi-site research. This was really important because in the VA, where women are a numerical minority, you can get enough men with heart disease in one VA with no problem at all, but you would need dozens of VAs to get the same number of women. And we also found at the time that women veterans research was itself extremely limited. Virtually all of it was descriptive, for example, assessing the prevalence of a condition. And it was chiefly mental health focused. And I can tell you, for the women veterans I work with, they want to very quickly remind everyone that they are not just mental health conditions. They are reproductive health, they are aging, healthy aging, and nearly adolescent health when they come out of the military early and join VA care. Most researchers were also just routinely excluding women. And in part, they would say there's just too few of them, they're too hard to recruit, or they weren't recruiting enough to look at effects by gender, or maybe they weren't even really interested in gender differences to begin with. Some of them didn't understand their healthcare needs or even how they used VA, and some were not familiar with VA women's health policy and priorities. For those researchers who are actually interested in women's health, a lot of them talked about having difficulty getting funding. So if you went to publish an article in a journal that was very used to publishing veterans research, they would often come back and say, women veterans, that's a thing. And in the cases of journals that were very oriented to women's health, they had a similar issue of not really understanding or having necessarily reviewers with expertise around women who were also veterans. And in other cases, they were having trouble getting their research, not just in terms of funded and published, they didn't necessarily have scientific review boards with adequate expertise as well. So we organized a national women's health research agenda that was what we call enterprise-wide. The VA has an intramural research program for biomedical lab, clinical sciences, rehabilitation, and health services research, which is my bucket. And we put together an infrastructure group, people who were center builders and initiative builders, and got their input and said, we need help figuring out how to build capacity, how to address the methodological limitations and barriers, and how to increase visibility and awareness of this work on the path to increasing the number of people doing work in this space, the number of people including women in their work, the number of grants that were funded, and the number of papers. So VA funded this infrastructure, fortunately, to build this capacity through the VA Women's Health Research Network, which I co-lead. I lead the Women's Health Research Consortium, designed to help provide training and mentorship, methods and technical support, collaborative research development work groups nationwide, and dissemination support to get to those journal supplements, to get to cyber seminars, to create briefings. And with a colleague, Susan Frayne at VA Palo Alto and Stanford, who leads the practice-based research network to increase recruitment of women, to increase multi-site research, to engage clinicians and leaders in implementation and impact of the work. We were then renewed within a few years to increase the achievement of the research agenda and to increase our research impacts, and added work by Dr. Allison Hamilton, who's a leading implementation scientist, to help us in that arena as well. So we then established a national women's health research services research agenda and geared up to look at access and rural health, primary care prevention, mental health, post-deployment health, reproductive health, and complex chronic conditions, long-term care, and aging, When we got started, there was not a single scientific published article on older women veterans. It was as if they didn't exist and that their healthcare needs had not been documented or anything. So all of these areas required a lot of work. So what we then did in this infrastructure was set up cyber seminars. We have over 90 online that are accessible to all of you as well. We developed these national research development work groups, for example, in women veterans suicide, in primary care and cardiovascular risk reduction as a couple of examples. We have a national mentoring network for women's health postdoctoral fellows and career development awardees. We convened conferences to hallmark the work in partnership with the Department of Defense, the Department of Health and Human Services, Department of Labor, et cetera. We provided technical support to bump up proposal fundability and built partnerships with operational leaders. So everyone could always be thinking about how their work might actually be deployed to improve evidence-based practice and policy. And then we engage women veterans in review and often co-design. Now, when it comes to the Women's Health Practice-Based Research Network, we started off with 4 sites, and we have now increased to 76 VA medical centers and over 300 community-based outpatient clinics across the United States. Over 90 studies have gone through the PBRN. And really our focus has been on improving readiness to implement evidence-based practice, to engage local employees in problem identification and solving that we can then direct research or evaluation resources towards, and to include the voices of women veterans in VA research. So we haven't updated this since most recently, but we'll be doing so soon. But as you can tell, we actually were quite successful in increasing the number of VA-funded projects focused on women veterans. This doesn't even include the number that started to include women veterans when folks realized that this was a priority, and the number of career awards. Both these numbers have doubled since this chart was put together, and we've helped get over $40 million of women veterans research funded and over 23 career development awards, which are akin to NIH-K awards with 5 years of protected time to do research. There's also been major increases in women veterans research publications. In our first review, the updated review found that more research had been published in the past 5 years than the previous 25 years combined. And in the last updated review, with one underway right now, found nearly 500 articles and increased topic diversity. And this most recent one is published in the Journal of General Internal Medicine to give folks an idea of what's been funded, where we have knowledge, so that we can move forward again on moving from descriptive and observational research to interventional and implementation science. The portfolio size and diversity has also grown over the last 10 years. As you can see, we still pursue and support research in post-traumatic stress disorder and military sexual trauma and substance use and intimate partner violence and other mental health concerns. But there's a lot more work in hepatitis C, musculoskeletal pain, trauma-sensitive yoga. You'll see a host of other areas here, a lot more work on contraceptive care, preconception care, maternity care coordination. We have a new career development awardee on sexually transmitted infections and more. So now I actually have the fun of sharing with you some of our transformational research initiatives, which has had me, despite wonderful opportunities and offerings to go elsewhere, has me firmly anchored in the VA. When I first started, actually, I used to tease people that they were VA lifers, and I have been in the VA now over 30 years, so I think I now qualify to be one. But my first studies focused really on how variations in primary care structure influence performance, and I could do that through national organizational surveys because I had hundreds of units. And as an epidemiologist by training, I was thinking about the organization of care, staffing mix, climate, care arrangements and the like as exposures within which physicians practice and what affects their ability to deliver high quality of care, and within which patients experience care. So as you can see, we were doing very well looking at primary care practice organization influencing colorectal cancer screening, the impact of primary care resources on prevention, and a host of other studies that we did in my first years in the VA. But I came into the VA with an interest in women's health at first and was told abruptly, oh, you need to shift that to older men. We kind of kept thinking, though, what are the women's health issues? We kept funding women's health fellows anyway. And I started thinking, wait a minute, what's going on with gender specific care? Can we find organizational factors that help us understand what kinds of organizational variations in care affect women's breast, and in this case, breast and cervical cancer screening rates? And we did find that screening rates were higher in VAs that had a higher organizational commitment to quality and higher anticipated rewards and recognition for basically doing the right thing. And that's all well and good, but that's kind of, to be honest, somewhat disappointing that we couldn't find more about what was driving quality of care for women. So these results were not consistent with our prior models. And I have to say, at first I was like, gosh, there must be something wrong with my models, bring in additional statisticians, work through them. And then I started saying, okay, the statistics are fine. The models are okay. It may be that women are using the VA differently than men, which is probably true outside the VA as well. And was their care organized differently too? And nobody knew the answer to that question. So we ended up studying how VA care was organized for women. And what we found was pretty shocking at the time. There were major organizational variations in how women experience primary care, for example. Over half the VAs have separate women's clinics, in addition to general primary care clinics, and about the other half have general primary care clinics. Now, in the general primary care clinics, on the right side here, they have no separate women's clinic at those locations. So really all the primary care providers see women, or they designate a women's health provider within primary care so they can consolidate the women to hopefully improve the proficiency and knowledge and expertise of that particular provider. In places with separate women's clinics, they often had women's health trained expertise. Sometimes they included a gynecologist, but the scopes of practice varied tremendously from very comprehensive programs that had strong gender-specific care, integrated a gynecologist, integrated a care manager and social worker and the like, and others were set up to only do gender-specific exams. They were called pap and mam clinics, basically. And then we also lifted the lid further to find women may go to one of those, they may go to both of those, or they may go to none of those and they get sent out to the community. So we really needed to do more work to understand this. So ultimately, I wanted to answer the question, do women's clinics matter? And we did a women's organizationally focused survey nationally, and we found, in fact, they do. Those VAs that have women's clinics and for whom women to go to those clinics had much higher rates of breast and cervical cancer screening. And women veterans were rating them, even though the clinics were open half the time as the general primary care clinics, they had higher rated access, continuity, and coordination. Interestingly, there was no other advantage in their other measures. And in fact, general primary care clinics sometimes did better, worse, or not significantly different on gender neutral measures, depending on the measure. So then we started thinking, okay, an organization within those clinics, how it's structured probably matters. And we found that was also true. So just a few examples. Women's clinics that were only staffed with nurse practitioners, no physicians, did not do as well on something like glycemic control measures. Part of that's probably because they are those those screening clinics and are not doing comprehensive services. Those VAs with more comprehensive women's clinics, interestingly, did not do as well on the gender neutral chronic disease quality measures, such as lipids or blood pressure control. And we started to learn through also qualitative inquiry that they were so focused on women's health that they sometimes did not focus on some of these other conditions as much. And some of that was that they were not staffed or resourced as well as general primary care. The very basic women's clinics that were basically screening clinics did better on incentivized performance measures because that's how they were built and why they were built. And then, not surprisingly, clinics with sufficient administrative staff, properly equipped exam rooms, chaperone access, and increased staff over the last few years did better. But that's not rocket science, even though it's helpful in designing better clinic models. So what happened next? What's the transformation part of this from study to something else? Within days of filing my final report on my study, I was contacted and asked to brief the VA Undersecretary for Health. Now that may not mean anything to all of you, but that's the person underneath the cabinet level. And that definitely got my blood pressure up a bit. I was then asked to join a new task force to redesign primary care for women. And a whole chapter of the resulting report was dedicated to our study results. I then spent the next 6 months briefing all the VA primary care directors in the country, all the VA women's health medical directors in the country, all the quality managers in the country about our research and its implications. And then the VA put forward a new handbook on healthcare services for women that included requirements for women's clinics or women's health primary care providers in general primary care clinics, and noted some of the organizational resources and arrangements from the study. Now, some years later, after we got to celebrate that and worked on additional studies, the VA shifted its primary care model to adopt patient-centered medical homes, but the policies were not adapted for women's needs. So why do we have to do that? Why do we tailor them? Well, again, women are the fastest growing segment of new VA users still, but they are fewer than 10% of our patients. So delivering gender-sensitive, comprehensive primary care is complicated by their significant comorbid physical and mental health burdens. To give you an idea, women have about comparable physical health and chronic disease burdens to male veterans, even though they're on average about 10 years younger, and they actually have higher mental health burdens. And then there's the need for gender-specific care from a workforce with gaps in provider and staff proficiency, sometimes gaps in gender sensitivity. We've had anecdotes of women saying they'd come in to see a doctor and they'd not have a limb, and they'd say, well, I lost that in combat, or I lost that on the lines, and they'd say, well, that's not possible. To have your doctor denigrate the fact that you're missing a limb is a problem, not surprisingly. And some variable comfort in handling trauma histories, problems with chaperone access, as well as privacy. A lot of these since then have been remedied, so I don't want you to walk away thinking the VA hasn't actually grappled with these things. But we still had some persistent gender disparities in quality and patient ratings of care, improved though from the last time I was mentioning it for my first study. And they had really begun to establish gender-focused primary care models, but how people managed to accomplish and implement policy varied. So now what do I do as an embedded researcher? Well, we needed a strategy for figuring out how to systematically tailor PAC to women's needs and then study it. So we decided on evidence-based quality improvement. Now, EBQI is a systematic approach to developing a multi-level research clinical partnership for implementing and tailoring care models to routine practice. You have to have we had national directives on VA medical homes, check. We had evidence from the prior work on primary care features associated with quality, check. We convened an expert panel to define gender sensitive comprehensive care for women, check. We then designed regional expert panels of multi-level stakeholders. And by that, I mean frontline clinicians, the head of women's health, the head of primary care, maybe the head of IT, somebody who's one of the medical center directors or director of nursing or something at the medical center level, and then the VA network level people, because all of those influence policy and finance and everything else in a particular clinical setting. We then helped local quality improvement teams design and implement local projects targeting the priorities set by that expert panel. And then what's odd for most researchers is we are really the technical experts, the educators, and the guides, because I, as a researcher, especially as an epidemiologist in Southern California, have no influence over clinical care delivery and resources in Minneapolis or New York or anywhere else. This also relies on quality improvement training, integration of measurement and formative data feedback, external practice facilitation, and adaptation to local context. Now, this is the field of implementation science, but it's really the processes you use for bringing a new care model into practices. And then I got VA research funding to test this in a 12-site cluster randomized trial in 4 VA networks. Now, long story short, those EBQI sites started demonstrating strong local gains really soon, improving access, follow-up of abnormal breast and cervical cancer screening, improved test result reporting. One group identified a process for assessing women veterans' emergent mental health needs before they ever came in for their first primary care appointment. That was hugely impactful, improving team function and the like. And then we helped local QI teams report their progress up the chain, meaning instead of Dr. Yano going in and reporting to their hospital director or their network director how great the people is I trained and make it about me, we said, no, we're going to teach you how to go report your team's work up the chain. And not only did it help those folks, many of whom got promoted up the chain fairly rapidly after their engagement in this project, it helped the senior leaders walk away with a tested innovation with data on its effectiveness in their contexts. And so that helped spread innovation through VA networks. And then as a result, the VA Office of Women's Health decided to adopt EBQI for deployment in their low performing VAs. And then fortunately asked us to evaluate its effectiveness in a second trial across 21 VAs. And we were funded to do that. So this was before the final trial results. Then finally, we finished the full trial and did indeed find that evidence-based QI had a positive independent effect on gender sensitivity among providers, team function, and lowered provider burnout. And in women's clinics, it promoted readiness to change. And in general primary care clinics, it significantly increased providers' sense of self-efficacy in delivering women's health care. Fortunately, the VA Office of Women's Health decided to adopt EBQI as a national initiative, and it is being rolled out in every VA in the country. So as this went forward and during this trial, I continued to be concerned about why some women only come to VA once and never return. That's kept plaguing me, and part of it were anecdotes from women veterans themselves about harassment. So I used the baseline patient care survey of that same cluster randomized trial and included novel survey items about experiences of harassment. And we really had no idea what we would find. And what we found was that 25%, 1 in 4 women veterans said that they had been harassed on their way to see their VA doctor. And we found that was associated with delayed and missed care. Now, well before we published anything, since this was partnered with the VA Office of Women's Health, we thought we can't wait to report this down the line after the year or two it takes to publish this paper. And we reported the results internally as soon as possible. The partner in this case immediately funded us to do a literature review on what works outside the VA, what works on college campuses, what works in military bases, what works anywhere, and can we adapt it to the VA? They asked us to conduct focus groups of men and women veterans to better understand the phenomenon, the experience, as well as we probably had some perpetrators of harassment in some of those groups. These were separate. And then key stakeholder interviews of people in the system to better understand where the levers were or existing structures that an end harassment effort could be plugged into. And then we did recommended an expert panel to combine that evidence to come up with evidence-based recommendations. Now, normally you'd think, gosh, that probably took 3 or 4 years. We had 1 year to do it all on operations funding, but it worked and we did it. Now, by the time the paper was published, I'm happy to say we are actually able to include the system's response in what the VA did in response to these findings. And that ended up having the paper become an editor's choice. And it went all over the place. And the paper then also got picked up by the press and congressional staff. Now, being good academics, we did publish the journey and the outcomes as well. Now, I mentioned the practice-based research network previously, and what we have been doing ever since that study findings came out was to design and put out a very simple anonymized patient survey, front and back, simple survey that clerks in these practice-based research network sites give out to 100% of the women veterans who come into the clinic over a two-week period of time. And 26 of our 70 odd sites said, we're willing to do that work. Now, we don't fund them to do this. This is something they do on a voluntary basis. In 2 weeks, we got nearly 1,400 of those surveys back. And as you can see, it ranged, the rate of stranger harassment ranged from 0 to 50%. Okay, so those sites that participate then in this data collection effort often use the findings to increase their local policies and test pilots for remedying and harassment. On the right side, you see one of their person-sized banners they have throughout their medical center, and one of the places that had the highest harassment going on. Having been to that VA, I can tell you there are structural things like walking down the hall and having the waiting areas all the way down for all the different clinics end up being an unintentional gauntlet. And they actually, in response to their local information, began to change physical plant to reduce that kind of feeling in their environments. And then we use the results to update VA leaders and Congress. So I actually have to write congressional reports that indicate what the results are for this effort, because we do this now every 6 months. Again, we are researchers, so we published a series and a mix of research and operations findings on results for all the different activities that I just mentioned, while new research is being funded on gender-based harassment, a bystander activation pilot. And as we started understanding the data for women veterans, we went, uh-oh, this is probably not just happening to women veterans, this is probably happening to staff as well and providers. So we surveyed and added the question to our provider and staff survey and found that regrettably, well over half reported being harassed in primary care and women's health in particular. So there's a lot more work going on there too. This Women's Health Research Network that I co-lead then developed a national harassment research work group to collaboratively develop more work in this area, with results reporting still going up the chain. I wanted to just give one more example of where we have research informing legislation and vice versa. So one mention is that the research on women veterans' pregnancy risks was actually used as part of VA's policy decision to allow abortion care. The House Veterans Affairs Committee, or HVAC, their subcommittee on health, has also added reproductive health as an initiative for veterans. And there is also a bicameral, bipartisan Women Veterans Task Force that we have had the privilege of briefing on research results repeatedly. The study we did also on women veterans harassment at VA was used by Congress to require VA to act on it. Basically, the VA was making really good progress on training staff, on bystanders, activities. I take now mandated training that has emanated from our own research. They've created different local staff that have to make ending harassment their job. But for Congress, it was not happening fast enough. So there's a host of policy actions they now need to take. And that includes a requirement for more research here. Congress also mandated expansion of a VA childcare pilot that was only 4 VA sites out of our 1,200 or the 170 odd hospitals. And it really actually would require an act of Congress to expand it. So Congress did, and mandated a national rollout so that there will be a child care center for all veterans who come to the VA for care in every VA medical center in the country. As you imagine, and they have to do this in 5 years. Fortunately, the VA operations side asked us to identify researchers who could study what veterans' child care needs were in order for them to design something that works for veterans. I can't tell you how many things in legislative terms go out and it's a mandate and people just do the mandate. And we're really fortunate that the VA relies on embedded researchers to make sure they're getting it right. Congress also mandated, and this was in the same legislation called the Deborah Sampson Act, actual mandated research on intimate partner violence. They wanted a systematic review on the prevalence of intimate partner violence among veterans, veteran partners, and subgroups of veterans, and to conduct an actual study. And then we were asked to identify ways to get this done within the VA. We then recommended an expert panel to bring together the systematic review and what turned out to be a big secondary analysis study of 18 different data sources. And that information is now gearing up to be given to a task force that's also mandated by Congress that will be chaired by the Secretary of the VA, the Secretary of Health and Human Services, and the US Attorney General, in combination with VA leaders and community-based organizations. So we'll make sure that all this research goes to them to make sure that whatever they design is evidence-based. So in summary, I hope I've expressed to you that explicit strategic planning, thinking about the infrastructure you need to build research, and doing so in partnership with operations and frontline providers enables you to transform women's healthcare, that this process works. It benefits from leaders who value research evidence. It benefits from embedded researchers who understand the system and its users. And it's important to have strategies for communicating and translating research evidence into terms other stakeholders can understand and use. I have to say that I've told my family, you know, it takes us about 10 years to learn how to write a scientific article so that we speak the language of our science in peer-reviewed literature, and about that long to lose our ability to communicate in lay terms to other people what we do. And this is just enormous. I want to impress upon you the enormous opportunities for transforming healthcare using the building blocks that you either have or are acquiring. It allows us to infuse the action plans and daily practice with evidence. And my cheat here is to say we're continuously seeking faculty collaborations and are always hiring, and I don't care where people live. But there are 18, as Dr. Luck said, 18 health services research centers of innovation, and there's one in Portland as well. So lastly, my email is down at the bottom right. I'm happy to address any questions today or address them through email later. So thank you very much for your time, and I'm happy to see if there are any questions.
Great. Thanks, Becky. Thanks for covering basically the nation's largest healthcare system and and the care it provides for women in a really short period of time. And for among our attendees, I'm sure there would be a round of applause if we were all in person. But I'd like to encourage those of you who have questions to put them in the chat. And so we've got, well, Becky, there's, I guess, one question that comes to mind, you know, based on your just your very last bullet there is for graduate students, especially, or, you know, PhD students, perhaps MPH students who are interested in understanding opportunities in VA health services research. I mean, and these are, and in our case, these would not be clinician,
Right.
not nurses and physicians, but social scientists. What would you suggest about how they would go about exploring those opportunities?
Yeah, a really important point there. It is true that the majority of postdoctoral fellowships that the VA has advertise around clinicians. There is a VA Health Services Research and Development Learning Health System, a postdoctoral fellowship that takes social scientists, so non-clinician PhDs as well. I'm pretty sure the Portland Coin has those. We have them as well. And I'm happy to direct folks to the website where all of them across the country are posted. But that's a 2-year fellowship with benefits that a few of my folks have extended to a 3rd year in order to, let's say, develop a career development ward, or some such.
Great. And this is a real prospect. There are 2 PhD graduates from health policy who are currently working at the Portland VA Research Center. So I guess I would also say that if certainly Becky's contact information is available, and then if anybody does have questions about VA, either I or Professor Denise Hines would also be more than happy to talk about VA opportunities for students here at OSU.
And actually, both of those are working on one of my studies, also from a distance. They're, in fact, one or both are presenting at the National VA meeting in 2 weeks, and both have got manuscripts underway. I think one of them it's under review already. And so, yes, we're very happy. One of the questions was hiring students on our team. Feel free to reach out to me. We, as I said, we have folks that are working on these studies in real time. We have folks that use data from these studies for dissertations. We help people sometimes do spin-off projects, and happy to talk to folks that are interested in a potential VA career.
Right. Yeah, and it's certainly something that I've enjoyed working on VA projects for the majority of my postdoctoral career.
And this is not health services research light necessarily. I have, over 270 peer-reviewed publications. I'm on the board of directors for Academy Health, our health services research one. I just yesterday was on a call with the National Academy of Medicine, helping them design a reproductive health focused annual meeting I work with the NIH Office of Research on Women's Health. It is not a second-class work life in any way, or academic life.
Yeah, and I guess I just want to make one there before a couple of questions. I did want to make one, just highlight one comment about something that I take for granted, but you really emphasizes in your presentation. Having so many sites in VA allows VA researchers to test out organizational models or other aspects of care delivery in a way that's really not possible in any other healthcare system. That's one thing I've always valued about working in VA. And then you highlighted today just how much quicker it is to be able to translate results of research back into impact. So I think that's one of those are a couple of benefits of working in VA, is having that environment and the ability to influence practice much faster than we can in other contexts.
Yeah, no, it's been incredibly gratifying. Folks that come to work at the VA, yes, we get our grants, we get our academic promotions, we publish, all those traditional markers of academic success are still there, but we are also asked, what impact, what difference have you made lately? And it's not a difficult question to answer, fortunately.
Great. Well, another I think related question about impact is from Professor Rupertella, I'm asking about, are there things that you all have learned about providing care to young women that you think are relevant for healthcare systems outside the VA, and whether you have any examples of working with non-VA systems about improving healthcare for women?
It's a great question, and one that could engender quite a lot of discussion, but let me say one simple example is just the collection and reporting of quality of care data by gender, by sex or gender. The reality is the VA finally did that, and they had to do a lot of work to oversample women so they had enough sample size, right? They had the statistical power to say anything. And they then turned around and took those data that we worked with them on, and then they navigated the process to get every VA network director in the country who has a performance agreement they have to succeed with, say which one of these gender disparities in quality are you going to choose, and you're going to focus and dedicate time to commit to improving. So when I talked about gender disparities in care, they then, and there's an article published in the American Journal of Public Health about this, the national improvement and reduction or elimination of gender disparities in care over the next 2 to 3 years was profound. You made everyone accountable, but you couldn't have done that if somebody didn't say, we're going to report quality by gender. And, we now have that issue, actually, speaking of gender, for our LGBTQ+ veterans, because there's nowhere in the VA data that they had sexual orientation and gender identity questions. That's now changed. We helped contribute a practice-based scan in our PBRN to assess what VAs were doing, because it was already mandated to happen, but nobody was putting in the right questions in the electronic health record. That's now happening. So now we'll be able to actually look at quality data for LGBTQ+, probably not L and G and B and T, but just sample size alone. But unless somebody presses for being able to collect data that way, and on the National Academy of Medicine call yesterday, they said that continues to be a national problem. In my setting, they're an extreme numerical minority. That's not true outside the VA. So those kinds of, so I think the approaches we've used would work very well outside the VA. And so part of what even was the discussion with the Bill and Melinda Gates Foundation the day before that was that there aren't enough devices, surgeries, pills, whatever, that are technology and innovation focused, that are for women's health conditions. And so in some cases, you can see we're trying to change the perspective on clinical trialists, right? We now mandated that they have to include women in their trials. But in talking to the Janine Clayton, who heads the NIH Office of Research on Women's Health, they're still not reporting sex-specific findings. So we don't know how basic interventions vary for men versus women, let alone Black, white, Hispanic. We just don't know, because people are not being forced to now publish the results. Even if they're null results, we need to know that. Right. So I've seen the push for getting people to publish sex-specific results. We actually did a whole journal supplement. You could not submit a manuscript unless you reported those specific results as a carrot instead of a stick. But there's a ton of work that can be done in that way. So it's policy, it's regulatory, and then at the end of the day, it's also our colleagues pushing each other and the system to collect data that will be useful.
Yeah, and I think you highlighted in several ways how just in your research and your answers, just making a system accountable for measuring and reporting performance by women is just the essential first step.
For it to not be, I mean, that was a talk I gave 10 years ago at Society for General Internal Medicine, and I had all these mucky mucks from different top organizations, and for that to still not be the case doesn't make any sense to me. So yeah, so there's some of them are like that. Some of them are gender tailoring primary care. There are private sector places that have already figured out that that is a niche market, but they're, we don't really know the quality of care they're delivering. We would want to make sure that that's being studied as well. There's so much outside the VA that is just understudied and underfunded.
So there's another question about mental health for women veterans. You alluded to that, but so Professor Wong asked about particular challenges for mental health care for women veterans and potentially the role of telehealth in VA for that.
Great question. And I actually had one more transformational initiative, one on PTSD and military sexual trauma, but I wanted to make sure I could get done in a reasonable time. There is actually on the PTSD and military sexual trauma side, which includes also depression and anxiety, because no one has just one of those conditions among women we see. There is a whole women's sciences division of the National Center for PTSD that is extraordinarily well funded, not only by Congress, but NIH and PCORI and a Walmart Foundation and a host of other groups to advance women's mental health research. And that's in addition to the traditional mechanisms I mentioned to you directly. So there is a tremendous amount of work in gender tailoring mental health care delivery, and in thinking about behavioral health as well. Just simple things like smoking cessation. There were counseling groups for smoking cessation in VA, and some of the women in those group counseling sessions would get tearful about trying to stop smoking, and the men would grumble, and there were these just unfortunate interactions that didn't make any sense. And so it's like, okay, well, are we going to create a separate women's smoking group? And a group went through a whole process to develop that, designed it, and no women showed up. So your second part about telehealth is really.
So we're actually right at our nominal time, but I think you were just finishing talking about some of the mental health services challenges for women veterans.
Yeah, if for those who are still on, and again, apologies with technology, there are women's mental health clinics. There are studies of how to improve gender-tailored treatment engagement and direct delivery services. And for any women who really are not comfortable getting care, not because of quality, but because of comfort in the VA environment, they get sent to and funded to attend care in the community. The challenge, of course, is that the majority of PTSD providers in the United States are actually in VA. It can be quite difficult to find a qualified person doing prolonged exposure therapy and cognitive processing therapy outside, but the VA figures that out too. So right. Apologies, that was definitely in a mode there right before I got that with the screen.
Okay. So I guess I'll have our one last question, just briefly from Professor Hines, was about, are there any projects underway between, with regard to women's health, between VA and the Department of Defense related to active duty or
it's a great question. We've actually, yes, and more is needed. I'd say one of the best examples is with the Millennium Cohort Study, which has oversampled, I think, over 100,000 women in the military, and these are longitudinal studies that have surveys that have been done, and administrative and chart data have been collected, and 70% of that cohort are now veterans. So the VA has already set up and linked the VA data with the military data with the survey data for the Millennium Cohort Study. And we've been working with them directly to establish collaborations for being able to analyze those data and publish on them. So we have a lot of those going on regularly. We also, I was asked to consider developing collaborative, very high level VA DoD women's health study. And I can't say more than that at the moment because we haven't picked a topic. I haven't identified a team, but the Department of Defense, the Uniformed Services University, and the Defense Health Agency are still really building their health services research capacity. And so that has taken more time to develop collaborations, but they exist now.
Great. Well, Becky, again, thank you very much for providing us a window into an enormous, not only clinical enterprise, but health services research enterprise. I'd like to thank everyone for joining us today. And please feel free to follow up with Dr. Yano, or as I said, me or Professor Hines, if you'd like to find out more about research inside VA.
And there's a lot of students, I'm getting emails that are interested. So
Great.
Get ready, Becky, you're going to get emails.
Okay.
Thanks, Maureen.
Okay. Yeah.
I have poor email boundaries. That works for me.
Okay. Thanks
Okay.
again so much. I appreciate it.
All right. All right. Have a good weekend, everyone.